Okay, thank you all. We're bringing the session coming up to lunch. That usually gets the juices flowing. So first of all, we thought we were going to be in a little bit more of an intimate setting for this. We kind of had a kind of a workshop type of flavour to this. And so if you want to participate, if you're in the back, could you kind of come up a little bit? All the messers at the back, you know, you were in school, you used to be like that again. So if you could come on up a little bit and we'll just have a bit more of a conversation than a lecture format. Okay, so that has the usual effect, they don't move. Yeah. Right, so who are we? Why are we here? Good question. So my name's Colin Doherty. I am a neurologist from James's Hospital. I'm also, somebody outside said to me, are you still doing that epilepsy thing? So like Mark Twain said, the reports of my demise are greatly exaggerated. I am still the national lead for the epilepsy programme. And we had a very good week last week. I was at 2 launches in the Royal College of Physicians. The first was of our model of care, which we've been putting together for the last 5 to 6 years. And then we also participated in the Epilepsy Ireland strategic plan launch. We've worked closely with the patient group. And there were 3 patients' stories at these launches. One was given actually by Joe Schmidt, who's the Irish rugby coach, and talking about his experience with epilepsy in his family. And then two other family stories. And what was striking, and I was just listening to Ger Kilkelly there talking, what's striking really about each of those talks was the emotional response deep that the patients gave. You could hear it in her voice, and each of those patients spoke like that. And I got this kind of shiver down my back thinking, oh my God, what have we put in this model of care? Because we've missed something big. You know, patients are talking about things that are not in the model of care. So if you're reading that model of care, it's just a start. It's a start, it's a good start. It's got a framework for process improvement. It's got a framework for measurements. But there's a huge amount of work to be done about getting patients involved. And that emotion at the heart of every patient's story is, like, we have to get over that first. Like, the patients have a huge amount to tell us about their experience. And it's just a hugely important thing. And I don't think we can measure it, actually. Famously, you know, when you read in newspapers people talking about the health service are misquoting Edwards Deming saying, you know, if you can't measure it, you can't manage it. What he actually said was, it's a mistake to say if you can't measure it, you can't manage it. And I don't think we can measure love and compassion and emotion. I don't think we can measure those things. And in fact, any attempt to measure them is an insult to the complexity. But we need to understand them. So we said, well, how are we going to understand this stuff? How are we going to understand? So somebody told me that we need to talk to anthropologists. Now, my understanding of anthropologists was the famous Gary Larson cartoon, which is, and it was Margaret Mead was depicted as arriving on a Polynesian island, and the natives were, quick, hide the television, here come the anthropologists. Anthropology, I think the best definition I can give you of that is, anthropology is the space between the surveys. Okay, it's the space between the numbers. It's the conversation going on that you can't measure. Now, that's not great for, you know, going to Liam Woods and asking him for, you know, because I can't measure this stuff, okay? And so we decided to, well, actually, we didn't decide. It was a fantastic process put in place called the RCQPS, which is a collaborative between ourselves in the clinical programs, the Royal College of Physicians, and in the HRB. And we did a speed dating thing about 2.5 years ago, where we were put in touch with a whole range of academic programs, which are not the usual collaborations that we have in medicine. And we met with Jamie Saris from Maynooth, who's from the Department of Anthropology, Medical Anthropology. And we realized this is the guy we need to talk to. This is the person who's going to help us understand these questions that can't be measured. And we've put in place this program about trying to understand even the very meaning of the term patient-centered care. What does it mean? I think if you took a survey in this, here we go, a survey from this audience about what they understand patient-centered care means, you'll probably get, you know, in and around the same idea, but it'd be very nuanced and people with different emphasis. So we decided to ask these people to come in and help us to answer this question using ourselves and our patients. And so we're going to present some of the preliminary approach that we used for this process. And to do that, we have Robbie Power, who's one of the researchers on the team, who's an anthropologist, and We also have a patient, Mandy Phelan, who's going to talk a little bit about her feedback. And then we're going to come back and we've a couple of questions to generate to try and get you guys talking about it. And that'll bring us up to the end of the session. Thank you. Robbie.
Hi, thanks very much for coming, and my name is Robbie. So what I'm going to talk to you about today is opportunities around how we're going to bring people together who use healthcare services and the people who deliver healthcare services so they can work together to better design what's referred to as patient-centered care. Over the course of the session, I'm going to talk a little bit about our project, and we're engaged in looking at epilepsy care. And we're working around this idea of partnership and co-designing. That's the main approach that we're taking. And indeed, we call our project the Epilepsy Partnership in Care project. We're using epilepsy then as epilepsy care as a lens to explore patient-centered care, really. And we're taking a very broad definition of that term, patient-centered care, and maybe challenging it a little bit as well. And we're thinking about it as a holistic treatment of a patient, but that for anthropologists, that means looking at a person's complete life, not just their diagnosis. So we're looking at person-centered care beyond their condition. And I might say this later on, but it's kind of from the clinic to the sitting room, if that makes sense to you at the moment. That's the kind of thing we're looking at. So as I said, I'm going to talk a little bit about our project, but to set the context for that, I'm going to ask a person with epilepsy to talk to you about it. And when she's finished, I'm going to talk a little bit about our methods. And then, as Colin said, open up for a discussion about this notion of patient-centeredness and patient-centered care. And by way of prompting you to think about that idea of centeredness or patient-centeredness, I wanted to say that in a previous role, I was a university lecturer and I'm a teaching and learning fellow of a university. And a lot of the work that I was engaged with involved designing systems or methods or processes that encourage student-centered learning. So that's really the first thing I wanted to say about that idea of centeredness. It's not exclusive to healthcare. It's out there in the ether, and it's involved in the commercial sphere. We talk about consumer-centered design. So to say that, firstly, is this just an in vogue term? Or can we realize it more fully? And the second thing to say to you is that in our observations in acute settings, I could say that pretty much everything I see is patient-centered, were I to go by the literature. Pretty much everything. All of the healthcare professionals are engaged in what could be described using the literature as patient-centeredness. With one exception, and that exception, and I know people are working to change this, but that exception is patients aren't involved in the design of the healthcare systems. So that's maybe those two things to leave you to think about before we get to the questions. It would be really nice if you just agreed with what I've said, but I'd like you to contradict me, if you wouldn't mind. So you might wonder why we're talking about quality and healthcare improvements, but I think the previous speakers kind of covered that whole idea that a more patient-centered approach, informed patients engaged in their own healthcare, self-management, you're going to have better, safer outcomes and more quality outcomes as a result of that. So then, a little bit about this idea that we're working in a healthcare system, which was mentioned before, that could be described as being a traditional system, insofar as the expert is often the person working in an acute setting, and they're delivering care in what could be described as a paternalistic way. Now, as a lot of people have alluded to already, there's a lot of work being done to change that, and really the only thing I want to say about that is that there's definitely more to be done on that issue. Our project is looking at this balance between these groups, these gaps, these spaces in between. That's where we're working. And we've heard things from healthcare professionals in particular that sort of shift this relationship, or what we would have thought of as hierarchies and barriers, where healthcare professionals are saying things like, I know my job, I know my role, but I don't know what it's like to live with that condition. And maybe this next slide kind of puts that into perspective when we talk about experts and where care should be delivered and who's delivering and how. I've never had epilepsy. I'm not an expert in living with epilepsy. I'm only, or just, and I've added that bit in, an expert in medicine. And that's to give that sense of that space that we're working in. Although we're looking at patient-centeredness, we're also working with healthcare professionals to see what do they need to bridge those gaps as well. What do they need in there too, and how can that be achieved? So our project is, it's surprising that I think it's 4 times now the word anthropology has been mentioned this morning, and I'm normally the only anthropologist in the village. So we're taking an anthropological perspective on this, and what that really means to take that anthropological approach to patient-centeredness is that we're trying to understand people from their point of view. We're trying to view the world from their eyes, and that's essentially what we mean. And we also mean by that we're looking at patients, but we're also looking at the people who provide healthcare to look at those things. So by way of kind of demonstrating what kind of data we collect, we have invited a person with epilepsy along to talk to you. And she's kindly going to tell you her story, and then I'll be back to you right after that. This is Mandy Phelan.
So, thanks, Robbie. Good afternoon, everyone. My name is Mandy. Today I'm going to share my own story of living with epilepsy with you. I was diagnosed with epilepsy in October 2014, and to be honest, the diagnosis came as a relief because I had multiple tonic-clonic seizures before being diagnosed, and at least now I knew what was wrong and that there was treatment for it. But at the same time, I felt very uneasy at entering into the unknown. At that stage, I was just too shy to ask questions and was very overwhelmed. For a long time following my diagnosis, I was embarrassed about the fact that I had epilepsy. One of the biggest struggles in the past few years was getting seizure control. Between coming to terms with accepting I have epilepsy and regular seizures, my confidence took a massive hit. Here I was, in what should be the prime of my life, 18 years old, feeling alone, embarrassed, self-conscious, and refusing to speak about my epilepsy. I knew something had to change for me to be happier and to start taking control of my epilepsy as best I could, because at this stage, epilepsy was dictating my life and I was allowing it to control me. I found local supports available to me and used the epilepsy specialist phone line when I needed it. I did a pre-nursing course in college. It went well at the start and I enjoyed it. The staff knew I had epilepsy and I told them everything they needed to know about it and seizure first aid. When I did have seizures at college, however, they panicked. Long story short, my epilepsy meant that I wasn't allowed to do work experience, which left me feeling isolated and different from everyone else. I met great friends in college who supported me through and were always there to help me should I have a seizure. So although it was a bittersweet experience, I have no regrets. If anything, my experience there made me want to show people, yes, I have epilepsy, but it doesn't define me. It was only when I did a presentation in college on epilepsy that it made me realise it felt good to be able to talk about my epilepsy. I think this was the first time that I had felt confident enough to actually say out loud, I have epilepsy, without being embarrassed about it. Soon I was talking about it to people that I had previously tried to hide it from because I was embarrassed. But now I feel empowered because I've seen how much talking about my epilepsy and being open has boosted my confidence and made me happier. Since then, life has only got better. I got all distinctions in my exams, and my college have agreed to let me do my work experience, hence I can apply for university. It's only in the last few months I have been seizure-free for the longest time ever. My regained confidence means I go out and do the things I love doing. I've gone travelling. I have a social life again, and I've organised fundraisers for Epilepsy Ireland and done the VHI Women's Mini Marathon back in June. I think my way of dealing with epilepsy is to stay positive and always believe in yourself and your capability. In May this year, I was in the intensive care unit as a result of a prolonged seizure. Back at that time in the intensive care unit, I wasn't feeling too positive, but then I reminded myself not to let epilepsy take over, and I thought of all the positive things in my life. There's so much to look forward to, and I refuse to let epilepsy stand in the way of that. Epilepsy may be in my life, but it doesn't own my life. I'm currently 7 months seizure-free, which is a huge achievement for me. My only regrets were hiding my epilepsy and not seeking support sooner. My thoughts on the Epilepsy Partnership in Care project and workshops that are with the approach of communication and collaboration between healthcare professionals and patients. I think it is realistic and is striving for better quality care, understanding and delivering care that is truly patient-centred. I feel this would undoubtedly benefit patients in their care. I personally believe this would be very useful as it questions why patient-centred care is not the norm, despite it being seemingly obvious. There are lots I could say about living with epilepsy, but I think I've given you a good insight into my experience of living with epilepsy and have enjoyed doing so. I would like to thank you all for your time and attention. Thank you.
So, you've kind of heard an example of the types of narratives that we are collecting through ethnographic research, and that's the method that anthropology employs. Essentially, we've been collecting patients' perspectives, and that was an ethnographic account or a narrative in action. Epilepsy was mentioned, I know, but there was a lot more mentioned too, and that's when we say a holistic approach to patient-centered care, they're the bits and pieces beyond the condition itself that we're talking about, looking at people in the fullness of their lives, as I said, from that clinical setting to the sitting room. So we heard about a lot about Mandy's life beyond her condition. That's really the point I want to make there. And that method that we use draws out those narratives. We're collecting those narratives from healthcare professionals as well, and carers and family members and healthcare managers as well. And we're doing that through various methods, one-to-one interviews, which are by default in anthropology a conversational style. So we don't have predetermined questions. We just talk to people. We listen to what they say about their world, and we try and see the world from their perspective. And then we're looking at sets of relationships and how they occur with people. As I said, with carers, patients, family members, community groups, nurses, doctors, and we're trying to understand all the socio-economic, historical, political, and cultural factors that give context to how these relationships occur as well. And then to say that that's a wholly qualitative method, so that's clear. So what we're trying to do then with that qualitative information is take some actions out of that. So we're blending these two research methods together. First, ethnography, as I say, gathering those stories from people. And then secondly, this thing, participatory action research. Now, these methods really lend themselves to working well together, and they align quite closely, and the objectives of them align quite closely too. So we take all of this data that we gather from people, all of those kinds of stories that we get from people. And what we're doing then is trying to build working partnerships, groups where people work together. So that ethnographic data is fundamentally informing these participatory action research groups. So we're bringing people together, and most importantly, they discuss issues that they have identified within the healthcare service, be they healthcare providers, be they patients, advocacy groups, whoever they are. They discuss issues that they have identified, and they discuss actions that they want to change, how they're going to change these issues as well. So we're not imposing things on people from above. It's a bottom-up kind of approach. Participatory action research comes from education. It's a learning by experience method, essentially learn by doing. That's the principles behind it. And to give you an example of one of these groups that we have in place, I know that's probably difficult to see, but within there, one of those groups is epilepsy community resource officers or groups. So we've brought together nationally groups of nurses and groups of community resource officers to discuss the issues that they face, to make each other aware of what they do in their daily job and how they could complement, are they doubling up on work, and how they could complement things that they're doing for the epilepsy services. So that's the kind of what a participatory action research group would look like, and we have a number of other ones in place as well. That's an ongoing part of the project, and we're developing these groups all of the time as we're being informed by these ethnographic encounters. So then before I hand back to Colin and open up for a few questions, I just wanted to give you some idea of the scale of this project. So we're working in 4 main centres, 2 in Dublin, we're working in Cork and Galway. We're also working with the Epilepsy Ireland, which is the patient advocacy group, throughout the country. And as I say, we're working with a lot of different people. It's a national project encompassing numerous participants in a number of settings. That's really the best way of saying that. In clinical settings, observations in hospitals, observations in the community, working with GPs, and then in people's homes. So then just to reiterate that approach to what we mean by a holistic approach to patient-centered care, it's working with people in clinical settings and then from the clinic to the sitting room. And I'll hand you back to Colin now and leave you with a few questions. Maybe you'll have more about this idea of patient-centeredness. Thanks very much.
Okay, so we have about 7 or 8 minutes before we're finished. So why don't we just throw it open while people are thinking about comments or questions. What I must say I have found, and I think Ger Kilkenny's speech was an embodiment of that when you work in healthcare and then you become a patient, it's a really powerful narrative to share with other people who work in the area. And I'll just share a very short story of my own. So this is pertinent to the question my mother's always said, that every medical student should be given a colonoscopy, which I think is probably true. I didn't volunteer for that though, myself. But we have another research project ongoing at the moment, which is in looking at exome sequencing. It's a very high-tech project looking at exome sequencing for patients with a very severe epilepsy. And I volunteered to be a control. So my DNA was sequenced as part of the control process. And so I got a phone call the other day from one of the guys running the project. And he said, now he's not a clinician, but he's just one of the scientists. And he said, Colin, I have to give you some feedback on your genetic sequencing. And I said, oh, right, well, I'm on my way in to I can meet you 5 minutes before the meeting. Oh, I need a bit more time than that, I think. So I was obviously then nervous. So anyway, I met after the meeting, and he'd gone through this process. And it turns out that I have this gene abnormality that's been described in a family with a cardiac condition called long QT syndrome. So my sodium channel, SCNA5, is mutated. And I have a potential of having this prolonged QT syndrome, which puts me at risk potentially of sudden death, of cardiac arrhythmias. Not only me, obviously, because it's a genetic condition, my family, my children. Now, I have a lot of work to do. I have to get these various tests done. But he sat there and he was explaining all this, and he'd spent ages going through the literature, and I could see the sweat on his forehead as he was telling me this stuff. But it is an amazing experience to be suddenly in that vulnerable position of being a patient and suddenly thinking about your own, because you actually then lose all the powers of rational thought that you bring to bear on most conversations that you have. And I think that, again, putting yourself in that position all the time as the patient is going to be a very powerful tool. And if people have experiences, they need to be sharing them with their colleagues. And that's going to start informing how we then have those conversations with real patients and how we bring them into the process. So can I throw it open there? Is there any comments or conversation? Yeah. We have a roving mic there. I might bring in other parts of the research team, actually. Mary and Jarlath, and would you come up, and Robbie, just if there's a question that I feel should be given to the other, and Jamie.
Thanks very much. That was a fabulous presentation. I really valued the work that you're doing. I'm Mary O'Riordan. I'm a public health doctor. And I suppose just on what you had said there about your own experiences as a patient, I wanted to ask, would it be valuable if we actually changed patient-centred care to person-centred care? I suppose bringing the fact that all healthcare professionals are actually also at some stage patients too, and it would mean that our system would then, if we'll say patients thrived on values such as dignity and respect, then if we changed to person-centred care, then healthcare workers would also thrive on the values of dignity and respect. It's just a view.
Jamie?
Does this work?
Does it work?
Actually, that's a very good point, and one of the kind of interesting parts of ethnographic work is where people use the same term, or because we're dealing with a lot of clinicians here, the same letter. You have a peculiar love of acronyms in your own tribe, and if you look at in both E, in e-health and the various E kind of things, and P, in patient-centeredness, you will see actually that sometimes it means patient, sometimes it means person, sometimes it means partner. Just as if you talk to so-called e-patients, that E only rarely means electronic. It usually means empowered and enabled. And I think that the important issue is not so much to get data. The only way that data is going to change anything is to wrinkle out those subtle variations. And a large part of our work in the EPIC project is to really put patient groups together where patients understand that the patient experience isn't singular. It's hugely different, okay? And it is not just defined by vulnerability. It's defined by aspects that are that would be labeled under resilience. And in the same way, the clinical experience is similarly not a monolithic kind of exercise. And it's putting the infrastructure in place where, and I think actually Ireland has a peculiar strength in this regard because of its scale and because of an engagement at the delivery structure, is people are willing, if they're given the space, to sit in the same room and work out not solutions that are going to be cookie cutter applied on scale, but understanding a system as a series of capacities that have to be actualized slightly different for individuals, who come with particular strengths and weaknesses.
Anything else? Just while you're getting the mic, speaking as a clinician, I think that's a very good point. If you look at Blonnet Hayes' survey of burnout that's happening among the healthcare staff, somewhere in the region of, and that was done specifically, I know, among medics. I'm sure there are similar surveys for nurses. In fact, there's one from the UK, that's name's escaping me at the moment. But we're talking about burnout rates, 40 to 60% among this professional group. And unless we start including our clinicians and our professional colleagues in the whole holistic approach, we're going to leave them behind. And I think it's a very important point. So now I'm not talking about patient-centered care anymore. You've convinced me.
Physician-centered care.
Okay. Sorry, yes, go ahead.
Eilish McCall of Health Systems, UCD. Just a fascinating set of presentations this morning. I think it's really powerful, and well done to all of you for sharing your experiences with us. And yours too, Colin, I think. But I'm going to be challenging here, and I'm going to pick you up on something you said as a throwaway remark. At the end of you sharing your story, you said, and that's good because it enables us to understand how the real patients feel. And I guess there is that distinction between patients and staff who might be patients, and I don't think that's very helpful. I think it's helpful, hearing the experiences of staff, but only because they speak in a language that us as healthcare professionals understand. But I think there is a tendency to categorize people as patients as if there's some other type of being out there. And, we all have the potential to be patients. We all have been patients, or we have family members who've been patients. So I think the language is very important. And just going back to what Mary O'Riordan said, I think we really do need to think about that. And what are we talking about? We are talking about person-centered and not patient-centered.
Yep, fully accept that. Even more convinced than I was a minute ago.
Okay, we're
One more question.
Hi, I'm Kathy and I work in disabilities. I suppose I was interested to see your mnemonic there of EPIC, which is empowering people in care, and its advocacy. I suppose I'm around quite a while now and I'm beginning to wonder, have things changed that much? And I don't personally believe they have. You know, when we all went through our training, be it in medicine or nursing or other disciplines of healthcare, we were always taught to look at the person in their entirety, not just when they were in a hospital bed or if they're in a GP or if they're in an outpatients. And I think the most valuable part of care was seeing the journey that that person took. And my biggest pleasure was always that aftercare in terms of how they were when they went home, how they fit back into their community. And I suppose having worked with patients with cancer, diabetes, renal failure, and now with disability, I don't think things have changed that very much, unless our training has changed and the people coming after me see it differently. And I suppose somebody used the phrase yesterday within the day was, let's get back to basics. And it is about basics, and it's about that holistic approach to not the sick person, but the whole person. So I suppose I'm just wondering, have things really changed, or are we reinventing it as a new philosophy, which I believe is still there, is the holistic person?
Okay, well, I might give the last word on that to Mary Fitzsimons, who's the principal investigator on this project. Mary's not a clinician, but she's been around clinicians for 25 years. So I think her perspective on whether things have changed or not. And by the way, she came up with the word epic.
So just thanks very much for all the comments, and they're very, very valuable. And first of all, I couldn't agree more with the notion of moving away from the concept of, or that label of patient-centered care. I absolutely agree with all the comments that have been made on that in regard to, you know, we've all been patients, we're all going to be patients. If we haven't been, I doubt there's anybody in the room who hasn't been, or who hasn't a family member who is currently. So we need to get away from that. What often strikes me in the last year is that Michael O'Leary, Ryanair, over the last year has commented a number of times, if he knew being nice to people was going to make him so much money, he would have done it sooner. So now, for example, we can bring 2 bags on board and all the rest of it. And in many ways, he's not treating his customers as kind of just people that he's squishing into the plane or something like that. So there's something similar in that. I think the point that you're making about has anything changed, I mean, you know, again, working in the health service, all of us here in this room, at least I hope so, know of all the fantastic things that happen every day in the delivery of health services and healthcare. And when I say that, I mean right across from community into the hospital-based setting and all the way around, all through the ecosystem. There are fantastic things. There are also things that we know could be an awful lot better. And actually, it strikes me, just going back to a comment on the previous presentation about the patient experience survey and widening the scope and all that kind of thing. What really strikes me is a huge amount of energy can go into collecting all this, you know, information about, you know, satisfaction and experience. And in many ways, we kind of know a lot of those stories. And I wonder, but I am biased, whether we really now need to just tip the balance and sort of say, well, why don't we put a bit more energy into the action learning and the action research? And I think, Kathy, what you're speaking about there really could be helped in that regard, in this idea of putting partnerships of people together to really drill through some of the issues around their services or around, we'll say, the ecosystem. The area that we're interested in happens to be epilepsy, but I think what we're learning is transferable to different areas. Robbie was talking about the example of one of our action research groups, which I think is really powerful at the moment. We're putting together a group of expert epilepsy nurses who largely are based in a hospital setting with a group of people who are largely based in the community. And they're hearing from each other about their individual roles and how they can actually complement each other in a way that the space hasn't been created previously to do that. And we're hopeful that that's going to create some conditions for things that will improve services, reduce waste in the system where maybe people are doing things that are already being done in the community and vice versa, and that kind of thing. So I hear what you're saying about has anything improved. I think lots of things have improved. But you know what? We could even do more, and we could do it using different techniques, that maybe we don't create the opportunities to do. So that's what I think. Thank you very much.